I'm Dr. Amol Gupta, and I want to thank you for joining me on another episode of Medicine Mentors, where we interview masters in medicine, leading physicians at the top universities across the United States to learn from their experiences and derive key insights, traits, and best practices that can guide medical students and residents. Today we have Dr. Christopher Jackson. Dr. Jackson is an assistant professor in the Department of Medicine at the University of Tennessee Health Sciences Center. He's passionate about education and is the associate program director for the Internal Medicine Residency Program and an assistant clerkship director of the medical school at the University of Tennessee. Dr. Jackson is also part of the core faculty of the Center for Health System Improvement. In a short span, he has received a number of awards and recognitions, including the Dr. James R. Gibbons Outstanding Resident Endocrinology Award and the NIH Young Investigator Award for Research, among others. His research interests include evidence-based practice, clinical reasoning, and my personal favorite, use of podcasts in graduate medical education. Dr. Jackson, this is an honor to have you join us on the podcast and have an opportunity to learn more about your life and experiences.
Thank you, Dr. Gupta. It's a pleasure to be here with you today.
So I'm going to start off with my favorite, using podcasts to improve graduate medical education. Can you talk to us a little bit about your experiences, not only with podcasts, but really bringing innovation into education? How can we make the experience better for both medical students and residents?
I really like this question. I think part of my interest in doing innovation in medical education is part of my own journey. When I was a resident, I was always told if you wanted to get better, you needed to just read more. If you read one more PubMed article, or if you read one more page in your MixApp, if you're an internal medicine resident, that was one of the keys to acquiring this knowledge that seemed so mysterious that all of my attendings had. But I noticed as I read more in MixApp or as I read more from PubMed that it was great, but I often wondered, well, how do you sustain this? Like, I feel others in my field have this access to information that I just don't seem to have. And when I was talking with one of my colleagues one day and they said, you should really start listening to podcasts. Now, I should say that I was never really big into podcasts before that, never really listened to them. Maybe I listened to an Audible book as, I'm driving up the road. But I said, okay, I'll check out a podcast. And I happened to check out the Curbsiders. And I was mesmerized. Wow. In 45 or so minutes, they took a topic. I believe the first one I listened to was a clinical reasoning discussion with Reza Manesh and a few members of the Curbsiders team. And I was blown away. I was like, wow, I could have spent 2 or 3 hours looking for the same information, or I could really engage with a podcast for 30 to 45 minutes. And from that point, I was hooked. I said, okay, I'm going to find some great medical podcasts and they'll be in my rotation of things I listen to. And then when I came on as faculty at UTHSC, there was an opportunity to really expand our ability to teach residents in the ambulatory space. And a lot of my residents said, Dr. Jackson, it just doesn't interest me. Like, why are you so excited, so passionate about this? And I said, why is it not interesting to you? Well, the education sometimes can just seem a little basic. It can seem a little boring. And for me as an ambulatory educator, I said, okay, there's got to be an opportunity here to engage residents more. And some of my residents were already listening to podcasts. So I decided, what if we use podcasts to kind of introduce topics to residents and then create a safe space in what was at the time an in-person report where we went through clinical cases, or now we do it via Zoom, where we take that knowledge and not regurgitate it, but we actually apply it to real life clinical scenarios.
I want to talk to you a little bit about your life story, your journey from childhood to current. Can you talk to us about some of the major turning points in your life?
Probably the first turning point that I can think of actually goes all the way back to high school. So originally I didn't even plan to do medicine as my career, as what I wanted to do. I actually thought I was going to do professional music, and I applied to go to music school, and it started auditioning process and everything was going well. And I've had this epiphany that while I certainly enjoyed music, there was always this tugging, this desire of how I could, combine kind of science and art. And while music certainly felt fulfilled, the art side, the science side of me was not fulfilled. And that actually pushed me towards medicine. And I think it's very important to know that, sometimes we get concerned if the path isn't linear. We think, oh, well, if I don't know right now what I want to do 5 years from now or 10 years from now, then I'm doomed. And that's just simply not true. And if you look at most successful people by whatever measure you want to define that as, all of them will probably share some story that their path was not linear, that, they did have moments along the way where they had epiphanies or turning points that pushed them to where they wanted to go. So my first thing is just, even if you're in medical school right now and you came into medical school saying, I know I'm going to be a surgeon, that's great and that's wonderful. And if you do that, that's awesome. But by the same token, if you decide, well, no, I actually find out I like another field, or, I want to do, some combination of medicine with public health or other things, that's okay. You're allowed to create your own destiny in that way. So that's one important point, is that, the journey is not fixed for sure. The second turning point was in medical school. So at least for me, up until medical school, I was used to being the star student. I always got the grades I wanted. I studied. Whether or not I studied effectively, we can debate, but I studied and I was used to getting certain outcomes. And then all of a sudden now I'm in medical school with everybody else that was at the top of their class and everybody else that, is quite smart and intelligent. And there can be some intimidation that comes with that. And for me, I think that intimidation and my own kind of personal fears manifested as, anxiety around taking tests and not studying effectively and being able to take the concepts that I was being taught and be able to use them on standardized exams. The big turning point for me was actually one of my last rotations, or I shouldn't say rotations, one of my last blocks as a first-year medical student that was in behavior and brain and behavior module. And in that module, I really struggled. And it was probably one of the first times academically I struggled so hard. And for me, it was a great lesson, one, and just sometimes it's still about showing up every day, making sure that even in the face of great challenges, you still have to persist. Number two, it was great to show me that oftentimes we think we are an island, in the sense we think that it's our responsibility to do everything on our own. And no successful person I've ever met has been able to get everywhere on their own. They have to use resources around them. They have to reach out to people.
What a journey. I mean, this was so inspirational, and a lot of questions come to mind. Let me start from the beginning, right? The part of your journey where you talk about in high school, you had this interest in becoming a musician, and it seems as if you've kept this interest in arts alive. Can you talk to us a little bit about how you've balanced the arts with the science that most of us associate medicine with?
Sure. My experiences with my patients have reminded me so much of the art. We think of innovation as, how do I teach something more effectively, or how do I do something cool with material that people find boring? And that is certainly innovation. But my first foray into the art of medicine actually goes back to one of the first patients I ever saw in my clerkship in family medicine, actually. She was a patient that dealt with a lot of medical issues. Probably a predominant medical issue was actually anorexia. And she had been to multiple doctors. She always talked about how nobody seemed to take her seriously, how everybody was just focused on medicalizing everything that occurred with her. And so I remember walking into her room while I was in my family medicine preceptor's clinic, and we just had a conversation. And I kind of put the science away for the side, and I kind of looked and said, well, if I were in her shoes, how do I take away all the medicalizing and kind of see her as a person? And I think that's one of the greatest arts of medicine, is actually to remember that there is a person behind a lot of those medical illnesses. And part of the way I keep the art of medicine alive is not being so fixated on guidelines, medical principles, that I don't forget to talk to the person that's in front of me and to go behind the medical diagnoses. I learned that she was a teacher and that one of her greatest passions in life were the students that she had. I learned that she had dealt with multiple challenges, with anxiety and other issues. And by the time we finished that conversation, she had smiled for the first time in that clinic that my family medicine preceptor saw. And he told me, if you can do that with every patient, then you have figured out what the art of medicine is. So to me, the art is being creative in how we engage with our patients and establish that therapeutic relationship and alliance so that we can partner together towards shared goals. So that's one way I keep the art alive.
There's a lot of this discussion that goes on about humanizing medicine. I think a lot of us individually try to brainstorm and say, okay, so what should I ask? What should I do when I walk in the room to really make that connection with patients? Can you share with us some of the things that you do to really build that strong trust with patients?
I would simply start by saying, expand your social history. When I was in medical school, sometimes we kind of whittled down a social history to, do you smoke? Do you drink? Do you use intravenous drugs? And that's not really a social history. That's just a history of your particular habits. A social history asks, where are you from? Who do you live with? What type of work do you do? What brings you joy? What makes you sad? Even asking simple questions like that, I have found out that I have taken care of teachers, principals, dancers. I found out that people like me really enjoy cooking shows. One of my patients and I were talking about Ina Garten and all the different recipes that she comes up with. I found just so much from patients just asking some of those questions. So I think it's really just about diving more into your social history. And number two, some of it is just your posture and how you're presenting yourself to the patient. So never talk to a patient standing up. Make sure you're sitting down. Make sure that if they share some of their humanity with you, you share some of yours with them. Now, I understand certainly there are things that are private and there are things that you can't always share. But I think when our patients hear us share some of those parts of ourselves, we don't get lost behind this white coat that we wear. They see us as people as well. There's, of course, a fine balance with doing that. But I think overall, when you do that, you open yourself up for your patients to get to know you more. And what I find is when patients know me a little bit more, they often trust what I have to say regarding, their treatment plans or what's going on.
So now that you've trained many students and residents, what would you say are the key traits and habits of the most successful and the most fulfilled physicians in training?
It's okay to not know. I still tell patients every single day, I don't know some things. But it's very important to match that with something. I don't know what's the cause of this particular symptom or problem you're having, but I will earnestly work to figure it out to the best of my ability. One kind of tells the patient, oh, well, the doctor doesn't know, and I guess they don't care, and I'm just going to have this problem for forever. Another says, hey, yes, I acknowledge you have this problem. I acknowledge that it is a significant impact on your life, and recognizing that I am going to do my best to figure out what is going on, but also acknowledging that I'm not just going to give you any answer just to pacify or to make myself feel better. I'm going to acknowledge that in medicine, just like in other things in life, there are things we don't know. Doesn't mean that we don't pursue the root cause, but we just don't know. So I think it's important early on and always to be humble enough to say, I don't know.
Dr. Jackson, this has really been an honor. I'm going to try to summarize all of the wonderful things that you taught us into really 3 insights that I'm taking away from this conversation. I'd say the first thing is that when the path is not linear, don't get concerned. Most successful people have shared a story in which their path was not linear. So we should continue to focus on finding meaning, finding purpose, rather than just hitting linear goals. And I think that's a huge, huge lesson that we learned. I think the second thing that you taught us is that medicine is not just science. And we're not just scientists, we're also artists. And rather than trying to prove that art in a classroom, our number one area of art is in that patient's encounter, in building that trust and creating that innovation, that experience. And you gave us some very good tools to do it, most important of which is taking a very detailed social history. And as we delve deeper and take the time to go into the social history, we'll find so many places where we can connect and create that bond with the patient. And that can be the stepping stone for trust. And the third thing I learned from your story is to be humble and to acknowledge what you don't know. But don't just say that you don't know something. Make a commitment to figuring that out and make your best attempt to help in that situation. Because if we don't know something and we're committed to fixing it, now the confidence comes in. So I want to thank you again for taking the time to share this wisdom with us. To our audience, thank you for tuning in with us here on the Medicine Mentors. Thank you for joining us as we learn from the Masters of Medicine.